Kia ora everyone, welcome to this Goodfellow Unit Webinar on common neurological problems. I'm Dr. Helen Fulcher, I'm a GP, and presenting our session tonight is Professor Alan Barber. He's a neurologist and a stroke specialist at Auckland City Hospital and the Neurological Foundation of New Zealand, Professor of Clinical Neurology. Welcome, Alan.
Thanks very much, and thanks for asking me to come along and present tonight.
Without further ado, I'll hand it over to you, Alan.
Thanks very much. And as I said, thanks for the opportunity to come along and talk. I've got a series of 4 cases. They cover most of the main neurology problems. One of the difficulties with neurology is that neurologists make it complicated because we're stamp collectors at heart and quite picky about things. But the cases I'm going to present tonight cover probably about 80% of neurology, and it's relatively straightforward. So without rabbiting on too much, I'll make a start. And I'm happy just to ask anything you want to ask about these cases. Just type your questions in. First case is a 20-year-old woman. She has a convulsive episode at a bar. So young woman, out, been drinking, collapses, has convulsive movements. What are the differential diagnoses for this episode? And how would you distinguish between what you think might have gone on? What investigations would you obtain and why? And what lifestyle advice would you give her? So I'll get you to start typing away for questions. I'll give you 30 seconds or so to ask away. So what do you think is going on here?
So we've got a few coming. Yeah. We've got hypoglycemia, epilepsy, seizure, brain tumor, alcohol intoxication, drug use, low blood pressure, recreational drugs, vasovagal. And someone has said they want to know what the blood glucose is. They want to speak to a witness. Was there any fall or head injury? And description around what happened, similar thing. Ask who was around to gain a better history. And someone suggested maybe Wernicke's encephalopathy.
Right. Well, yeah. I was a bit worried this was going to be a bit slow with all the questions, but in fact you're quite chatty, so that's good. Okay, so loss of consciousness and convulsions. What could this be? Well, seizure, epileptic seizure. She's had abnormal movements. So that would be at the top of my list. The second possibility is convulsive syncope. I don't know if you've ever seen anyone have convulsive syncope, but it's actually quite dramatic. I have, sitting at a restaurant, and someone fainted, and initially I thought they were having a seizure, but it was, they were pale and sweaty. So those two, you definitely want to know what the blood glucose was. But I've seen people with hypoglycemia don't just have a convulsive episode. They go down, they become drowsy and irritable, and so you wouldn't really expect them to just have a convulsion, although if their blood glucose goes really low, then that's a possibility. With all those other things like Wernicke's and brain tumors, I mean, just pick with the simple things. I would see someone like this most weeks as a neurologist. And, they've almost never got a brain tumor, and it's a little bit too young for Wernicke's encephalopathy. So top of my list would be a convulsive episode as a result of a seizure or convulsive syncope. Those would be my 2 main differentials. In terms of the investigations, I agree absolutely she needs blood glucose done. If she comes to see you in your practice, it would be worthwhile. You want to make sure she's had a blood pressure. I'd do a lying and standing blood pressure, ask if she has problems with getting dizzy if she stands up too quickly, and if at all possible, get an ECG. So that's how I would start. you know, if I wasn't in a hospital situation. In terms of lifestyle advice, it depends on what you think this person might have. If you think this person has fainted, then she'll have a prodrome, and she would have had symptoms whereby she's become, you know, dizzy. She might feel nauseated, hot and sweaty, feel as if things are closing in. There's a prodrome. The lifestyle advice I would give to a patient, if that's the case, is get on the ground, lie down flat, straight away. You know, wriggle your legs. If you know, that's what I would do in the first instance. But do you have? I'm talking too much. Do you have any other points you'd like to ask or questions you'd like to ask?
So, Alan, someone's asked, is a convulsive syncope the same as a vasovagal collapse with convulsive-like movements? Yes.
Yeah, it is. So, I mean, I've always taught that you get a few myoclonic jerks after you faint. Particularly, I saw a patient last week, a young man, at a movie, watched a horrible scene, and fainted in his chair and had reasonably prolonged myoclonic jerks because he was still sitting up, and so the blood wasn't getting to his brain, and it lasted a little bit longer. So it can be quite dramatic. Patients with convulsive syncope can also have incontinence, and they can also bite their tongues. So it can be quite tricky.
Is the speed of recovery important, or the length of the postictal period?
It absolutely is. And so there's a prodrome with syncope. Once the person's flat, the blood flow gets restored to the brain, and people regain consciousness quickly, you know, within seconds, certainly within a minute or so. They're often a little bit dazed, what the heck just happened, but then they're back to normal, unless it happens again. Whereas someone who's had an epileptic seizure, that's enough to lose consciousness and fall on the ground and have a seizure, you're going to have post-nictal confusion because there's been widespread electrical activity in the brain, and it sort of stuns the brain for a bit. So that post-nictal phase lasts a little bit longer. So these are the points in the history you want to tease out.
And there's a question here, questioning here about how much alcohol she's had, and is there a connection between alcohol and seizures?
Yes, yeah, okay. So, yeah, of course you've got to make sure that the person isn't just drunk and fell over, but, you know, this person's had convulsive movements. So, but you want to know from a witness, you want to know what they've taken, how much, you know, it's alcohol, but have they taken anything else as well? Marijuana will reduce a seizure threshold. This young woman might have known epilepsy, and marijuana will lower the seizure threshold. Too much alcohol and not enough sleep will also lower the seizure threshold. Patients often come in after a big night out, either usually first thing in the morning when they wake up, that they'll have a seizure because of sleep deprivation and alcohol. They also lower seizure thresholds. And
Alan, if someone has a convulsive syncope, do the patients tend to have a postictal period? And does a convulsive syncope have the same implications for driving?
So no, that's what I was saying. That if it's a faint and you've got some convulsive movements as a result of the faint, the syncope, then they come back to normal almost immediately. Okay. Look around, days, what the heck just happened, but they're pretty much back to normal straight away, certainly within a minute or two. And so that's how you can help distinguish between an epileptic seizure and syncope. Having a faint has implications for driving. And if you think this patient's had an epileptic seizure, you need to stop her from driving until it's been sorted out. If you think this patient has had syncope, and you're quite happy with that, and you're not going to refer her on, then there's still a driving restriction. I think it's 2 months. I always look it up. If you're not sure, you have to treat it as if she's had an epileptic seizure, and tell the patient she can't drive.
There's also a question about how do you differentiate between this and pseudo seizures?
Oh, well, that's neurology level stuff, and it can be more difficult than you think. The best way to do it, the way we do it, because we see a lot of pseudo seizures, and we've got a video EEG monitoring unit where we bring two people, hook them up to the EEG and a video on them, and we keep them for up to 5 or 6 days in the hospital. So it can be quite difficult to determine. But you can, if you get someone who's got a video of someone having a pseudo seizure, you can often pick it out. There are often little clues. The movements are abnormal. You often get thrusting of the hips, and so that's usually a giveaway.
There's been a couple more suggestions about things to ask. So one is about medications, sulfonylureas, and also about a cardiac.
About a cardiac. Yeah.
A cardiac history, preceding symptoms that may suggest a vasovagal maturation or a heat, things like that.
Yes, absolutely.
And someone has asked, apart from marijuana, are there any other recreational drugs that commonly lower the seizure threshold or commonly cause seizures?
As I said, marijuana definitely does.
Yeah.
The other ones, it's probably the big night out, being sleep deprived, that lowers the seizure threat.
Okay, and then a number of people have asked, would you do an EEG in this situation, and should we be referring her through to neurology?
Yes. If you're happy that this was a faint, good going, I was lightheaded, I felt sick, I thought I was going to vomit, things closed in, so I was conscious but I couldn't see, everything sounded muffled, and you get from the witness they turn pale and clammy, and then they slump to the ground as opposed to falling. They had a few jerks and they were back to normal. Then you don't necessarily, if you're comfortable, you don't necessarily need to refer to neurology, but often you will need to refer to neurology. It's good if you've got a lying and standing blood pressure, pulse. If you can get an ECG, that's really good, because then when we see her, we've got a fair idea, and refer her off to the first seizure clinic. We try and see those patients within a month. It's not always possible, but we try to. In the meantime, you've got to tell her that she shouldn't drive. If you're not sure what's going on and it could be a seizure, an epileptic seizure, then you need to tell her you need to be careful around water, fires, and heights. So it's not just the driving, you need to give safety advice, because if she had another one of these while walking up a ladder, or while sitting next to a fire with a flickering light, or while swimming, that could be disastrous. So you need to tell the patient this and write it in the notes.
Is that safety advice pertinent if they've had what you think is a convulsive syncope then?
No. If you're comfortable, when I see someone with a convulsive syncope, I say, this is what happened. This is what you do next time it happens. You wriggle your legs and lie on the ground straight away. So I don't. I mean, the lifestyle advice goes for as long as the driving advice. So in the next couple of months, no swimming, no up ladders, and be careful around fires.
And Alan, if the EEG has ruled out an elliptiform cause of the seizure, could you safely allow that person to continue driving?
No. So we would see her in first seizure clinic. We would do an EEG. The EEG, and this is a good take-home point. The EEG in someone who we absolutely know has epilepsy is normal 50% of the time. So epileptic seizures come and go, and the abnormal electrical activity in the brain comes and goes as well. And so around half the time, the EEG is done when there's no abnormal electrical activity in a patient with known epilepsy. If you then take those half of the patients with a normal EEG and do another one, then half of those patients will have a normal EEG, and so on and so forth. So I always warn patients, I'm going to do an EEG. It's really helpful if it's abnormal, but there's a 50% chance that it's not abnormal. It's helpful to make a diagnosis, but it's not helpful excluding a diagnosis. So that's a really good question. And a normal EEG doesn't exclude epilepsy.
Okay. There's also a question around the ECG and what you're looking for on the ECG and presuming cardiac cause.
Yeah, what are you looking for? The ECG. You want to, is there a heart block? I've certainly seen an EEG. I don't report EEGs, but when I was a registrar, I did. Seen an EEG, and the patient had severe heart block, and sorry, not heart block, was having little periods of asystole lasting for up to 20 seconds. Because when you do the EEG, you do an ECG at the same time, and we're looking at all the waves on the EEG, and it took a little while to twig that she was having these asystoles. So it's important to do.
Someone else has wondered about Wolff Parkinson's White syndrome as well, looking for something like that.
Yeah. So it's any arrhythmia. Yeah. But, this is a 20-year-old woman. The EEG's 10 normal.
Yeah. There's been a question if a 17-year-old faints after a vaccine, is there a driving restriction at that point?
Yes.
Okay. And what is the longest syncopal period that you've seen? This is someone who's written to say, I had a patient hungover with needle phobia, food deprived, then had a needle for hand injury, and they didn't breathe for about 20 seconds.
Yep.
So this happens.
Yeah, see it all the time.
Someone else has had an experience of a convulsive syncope that happens several minutes after the faint. Is that common?
Yes, yes, it can be. I don't know about 7 minutes, but I've certainly seen people who have fainted and then get up and then have another one and then have convulsions. I've certainly seen that. And every time they sat up, it would happen again.
Do you recommend a CT head after one episode of a seizure?
So it's hard to, if the patient turns up in ED, it's hard to get through ED these days without a CT scan. But it's not the best brain imaging modality. So MRI is the best brain imaging modality. But by the time they get to a neurology first seizure clinic, they've had a CT scan. We often have to repeat and do an MRI scan. It depends on the sort of epilepsy. If someone's got generalized epileptiform changes on the brain, so the EEG is just an ECG of the brain, basically, and there are multiple electrodes, and the electrodes reflect the underlying electrical activity. If you get bursts of generalized electrical activity across the whole brain all at the same time, that suggests a generalized onset epilepsy type. Though these are the type of epilepsies you've inherited, and probably the most common. A young woman like this is almost certainly going to be a generalized onset epilepsy. And so those patients, if you see generalized changes on the EEG, we don't do a brain scan at all. If the EEG is normal, or more importantly, if there are focal changes, there's electrical activity on this side, but this side's okay, then that suggests there's a lesion under there, and then they definitely need an MRI, even if the CT scan was normal.
Good, that was one of our next questions coming through. So I think, Petra, you've asked, so people who've been diagnosed with epilepsy in the past who are not on any medications, can they have a normal EEG? And I think, Alan, you've said yes, that's right.
Absolutely, yeah, 50% of the time, so quite a lot.
Yes, and then a couple of people have asked, when do you refer for an MRI and what MRI features do you see in a patient with epilepsy? And that's when you're looking for a more focal cause, is that right? Yeah,
so with the MRIs, as I said, there are different types of epilepsies. There are focal onset epilepsies and there are generalized onset epilepsies. The generalized onset epilepsies, the whole brain goes off at the same time with a burst of electrical activity. The focal onset epilepsies, the electrical activity will start in one part of the brain and then spread. Okay, and that's why you get the epileptic march or the Jacksonian march, handshake, arm shake, then the face, and then you're on the ground, as the electrical activity spreads across the brain and stimulates the underlying brain cells. And so if someone's got a generalized epileptiform change on the EEG, we don't get an MRI scan at all. If someone's got a focal change on the EEG, we definitely, and we're looking for, depending on the seizure type, we're looking for tumors. The most common cause of seizures is actually strokes happening in older people. But we look for something called hippocampal sclerosis, which causes focal impaired awareness seizures, where we think what's happened is that as a child as an infant or a young child, the kids had a viral infection that's had a predilection for the hippocampi, and one of them becomes shrunken and scarred. And then later in life, that shrunken, scarred hippocampus irritates the surrounding normal brain. And these are what we used to call temporal lobe seizures. You get, because it's the memory part of the brain, hippocampus, you get deja vu or jamais vu. You know, this has happened before, or I'm in my house and it feels like I've never been here, but I know it's my house. And then they get impaired awareness. So that we do an MRI scan looking for focal epilepsy causes.
Thank you, Alan. Just a couple more questions, and I think we'll move on because you're going to answer some of the next questions as we carry on. One is, can you have hormonal epilepsy?
Yes, catamenial epilepsy. Yep, absolutely. And so we will often give a woman who's having seizures in the lead up to her periods or wherever in the cycle, because it tends to be quite clear, we'll give those women clobazam or clonazepam for 5 days of the month in the lead up to the seizures.
Okay. And for a teenager with suspected absent seizures, what features of the MRI is essential to diagnose these?
Focal changes. Well, let's just go through that. Absence seizures are a generalized onset epilepsy, and absence seizures are quite distinctive. They're sort of like this: you're talking along, and then you're back to normal. That's an absence seizure. What patients call absence seizures are often focal impaired awareness seizures, temporal lobe seizures, where they lose a longer period. They get an aura. They may smack their lips or pick at things. They get a funny feeling, butterflies, a funny taste. So there's a difference between what patients call things and what they actually are. So absence seizures are quite a specific thing. They're a generalized onset. The whole brain, you get a burst of electrical activity, 3 Hertz spike and wave on the EEG, which is different from the focal impaired awareness seizures. Okay.
Look, thanks, Alan. I think there's a few questions on medication, so I know you're coming up to that, so let's move on.
This is only my first slide.
You've covered a lot.
So take-home messages: seizures versus syncope. It all rests in the history. Okay, you need to call a witness if the patient comes on their own. It only takes a couple of minutes. Did anyone see this? Oh yeah, my boyfriend is. Where is he? He's at work. Pick up the phone. What's his number? You know, I'm with Sally. I understand you saw what happened. Tell me what happened. And it literally takes 2 or 3 minutes. And it makes a huge difference because, you know, it really does rest on the history. Syncope has a prodrome. The patient can remember it. They're lightheaded, nauseated, sweaty. It's called a blackout because what happens is the vision closes in and they can't see, but they're still, for a split second, conscious. So that's why it's called a blackout. And sounds can sound muffled. They tend to go down softly. They don't fall like a rock. They can get a few clonic jerks, and they can have urinary incontinence. And seizures, an epileptic seizure, you want to know, did the patient have any symptoms beforehand? Was there any deja vu? Was there any rising sensation, butterflies in the epigastrium, which is quite characteristic of temporal lobe seizures? Or did the patient just have no warning? You know, how long did the seizure activity last for? If it's lasting for 3 minutes, it's not convulsive syncope, which tends to be just a few myoclonic jerks. And were they confused afterwards? Epileptic seizures, they're confused for a prolonged period of time. Syncope, they're back to normal pretty much straight away. You've got to tell patients about safety. Okay, this is really important, and we often forget to do it. You know, I don't know what this was. I'm going to send you to the clinic. It's going to take a little while before you get there. In the meantime, in case this happens again, you've got to be really careful around water, heights, and fire. Okay, if you have one of these and it's an epileptic seizure and you're swimming, you may not wake up. Because you need to be very direct and very clear. The patient, if you don't know what's going on, or if you think it's epileptic, you have to tell them about driving. And the driving rules are 12 months. And so you need to tell them that. Now, you also tell them the neurologist can often get it down to 6 months if it's epileptic. So they turn up to their clinic. But you need to flag this in advance. And I guess you don't have to worry about this as GPs, but we tell patients about, if I think it's an epileptic seizure, particularly when you're starting treatment, I tell patients about the very small risk of sudden unexplained death in epilepsy, SUDEP. I've only seen it once in 20 years, touch wood, but patients can very rarely die during a seizure. And it's important to let people know, because, you know, sort of particularly when you're starting treatment, we're starting treatment, and this is one of the reasons why, because this happens more commonly in people who don't have medication, they're not taking their medications, and they've got uncontrolled seizures. So it's really important to get those seizures under control. So those are the take-home messages from that first slide. Oh, the other thing, sorry. If you think this is epileptic, or if I think it's epileptic, I don't start medications after the first seizure, okay? Half of patients only ever have one seizure. I'm talking about epileptic seizures. And so after a single seizure, we don't start medications. And so those lifestyle and things, the safety things, are really important. But you warn the patient that there's a 50% chance, if this is epilepsy, that you'll have a second seizure, and then you'll definitely need to be on treatment. There are occasional exceptions. So someone with a focal onset seizure, I'll start therapy. That's where the sensation starts here, moves up, or the deja vu temporal lobe seizures, or the focal motor seizures, where just a hand wriggles, or I will start the treatment on those patients after a single one. And someone who's got generalized epileptiform change on their EEG, they're going to have more seizures. I start treatment straight away. So, moving on, 1 month later, she has a second convulsive episode, and it's clear that this woman has epilepsy. Okay, so you've got a good history from a witness. There was no warning. The seizure activity lasted for 3 minutes. She bit her tongue and was incontinent. By the time the ambulance was called this time, and by the time she got to hospital, she was still confused and she can't remember anything. And so this is clearly epilepsy. And so you decide to start treatment. So what anticonvulsant medications might you consider, and why? So if you could type away and give me some potential answers. So thinking of this particular case, young woman, second seizure, definitely epileptic. She's still on the waiting list to be seen in the first seizure clinic. You're going to have to do something. She now needs treatment. It needs to be started now, because who knows when the first seizure clinic appointment is going to be. So what anticonvulsant might you consider?
So we've got a lot of votes here for levetiracetam.
Yep.
Epilim also coming up.
Yep.
Not sodium valproate.
Which is epilim. They got 1 for, 1 against, but yeah. Yep.
That's pretty well it. Levetiracetam is the vote. I think a number of people have said the same thing. And,
so let's go
we've actually had a question come through, which is, should we start the anticonvulsive treatment before the neurology assessment if it's convincingly sounding like epilepsy? Absolutely.
She's had 2 seizures now in a month. She's at risk of having further seizures. She's declared herself as someone who's going to have epileptic seizures. Who knows when the neurologists are going to see her? And so you need to get her safe and start treatment. And
there's lots of comment about teratogenicity and making sure that she's safe because she's a young woman, using contraception, mazepine, lamotrigine.
I'll come back to those ones in a minute. We'll just go through the medication. So these are them. So you often get confused about the epilepsy medications, but this is literally it. There are no more. So, and even I don't use lacosamide. That's the That's the epilepsy super. I'm a stroke specialist, so that's the epilepsy super specialist that use that one, and you have to try all these other ones beforehand. So these are the options. This is it. Sort of 5 drugs or 6 drugs. So levetiracetam is the first line. That's what we would use. The junior staff love it because you just start it straight away. 500 milligrams twice a day, 750 to 1,000 milligrams twice a day for a big person, and you start at no titrating up, very few or no interactions really, and so that would be the #1 choice at this stage until we get new epilepsy medications. Just as a warning, about 10% of people with levetiracetam develop depression and anxiety, and it's not subtle. It just comes on out of the blue and can be quite unpleasant. I had a lawyer who started getting panic attacks, sort of, a couple of weeks after starting this medication. And so I warn people about that, but it's very safe otherwise. It's very, very safe. So that would be #1. Lamotrigine is a good drug. It's sort of taken the place of carbamazepine. It works really well. It's good for different epilepsy types. The only problem with it, it takes a couple of weeks to a month or so, 6 weeks to get up to the full dose. And so, you start 25 milligrams at night for a week, and then 25 BD for a week, and then 25 and 50 for a week, and then 50, 50, 75, 70. So it takes a little while to get it up. And it depends on how worried you are about this particular patient having more seizures. So these would be my 2 top first lines. Topiramate, second line, causes problems with mood. People lose weight. Valproate is a really good drug, but to be honest, we use it as a second line these days. These medications are better. It's really good for primary generalized epilepsy, the myoclonic epilepsies, but we tend to use it second line. It makes you put on weight, get acne, and you lose your hair. So avoid it in women. And we'll come back to valproate in a minute, why we avoid in women. It's all of these medications potentially have problems to a developing fetus, but valproate is probably, twice as bad as the other ones. So we just avoid it in women. Very rarely you might see a neurologist using valproate in a woman, but we've thought about it. Sometimes it's the only medication that works. Tegretol is right down the bottom. It's second or third line these days. I can't remember the last time I used Tegretol. Lacosamide, I've never used because, sort of, if you get into this stage, that patients failed everything else. There are multiple epilepsy medications before you can prescribe it. And so I'll send off to Peter Bergen or Liz Walker, who are epilepsy specialists. Phenytoin we don't use anymore. We use it in ED to load people in status, but we don't use it. Having said that, if someone's been on phenytoin for the last 30 years and their epilepsy is stable and it's not causing them any particular grief, that's fine. So any questions about the specific medications?
Yep, we've got a couple of questions about whether you have an opinion on lamotrigine and Lamictal funding. Someone's had 2 or 3 patients with breakthrough seizures and switching to generic. And have you noticed any differences?
If they're having breakthrough seizures, the dose probably was only just keeping them on the Lamictal, and the change to the generic, there's been a slight difference. It just means the dose needs to go up. My personal opinion, no, I don't think there's any particular difference between them. I don't want to get into a big argument about it, but pharmac's constantly changing the preparations that we can prescribe, and this is no different from anything else.
Yeah. Okay. I have a comment from someone who said, please clearly document your informed consent and discussion regarding teratogenicity. That's just a quote from.
So back up on that. When you see a patient with epilepsy, and this is for me, but it's also for you, when you see them, you need to talk about safety. You need to document driving, and if you're starting the medications, you need to say that we discussed in brief the potential risk to a fetus of the medications. But, you know, I will leave that to the neurology team to discuss in further detail when she's seen. But documented, definitely documented.
If someone develops anxiety on the levetiracetam, would you change the anticonvulsant or would you treat the anxiety?
No, change the anticonvulsant. And I would change the lamotrigine probably. And I'd overlap them. I'd drop the dose of levetiracetam down a little bit, start the lamotrigine, say, look, can you handle it for the next month while I get this other medication going, and do it like that. And as long as you tell them it's a side effect, it depends how bad it is. As long as you tell them, and, you know, I've reduced the dose a little bit, let's just keep it going until we get this other one, you know, fully in your system, and then we'll take the levetiracetam out. And as long as you tell the people what you're doing, they usually tolerate it.
Okay. And is there any case for doing routine blood levels?
No, not really. The blood levels are good for phenytoin, they're good for carbamazepine. People do them on valproate, but they're really only helpful to find out if someone's taking it or not taking it at all. The actual therapeutic range, I don't pay too much attention to with valproate, but you can tell if someone's not taking the medication. Lamotrigine, very occasionally I'll do a level, but these are good drugs. You know, the problem with phenytoin was it had saturable kinetics, so you could go from, and it had nasty, and carbamazepine is the same, had nasty side effects if you had too much. You know, with the ataxia and confusion. And this drug, phenytoin, you could go from 300 to 330 milligrams, and the free levels in the blood would just skyrocket, causing problems. So it was important to do levels with these drugs, but these older drugs, but these newer ones, hardly ever do them. Mainly just to see if someone's actually taking it.
Okay.
That's probably the major.
Of course.
That's probably the major reason for people's seizures continuing, is that they're not taking it.
Can you have people on both your two first-line anticonvulsants there? Do you have them on more than one very often?
So 80% of people, you can get the seizures under control with one medication. Okay, so that's as long as they take it. It doesn't work if it's in the bottle, but if they take it, 80% of people, you can control the seizures. 20% of the patients, it can be really difficult. And so what you tend to do is you start with this one, and they're still having seizures. So you add this one, and then you withdraw this one, and they're still having seizures. And you think, oh, goodness, what am I going to do next? And you start this one, and keep these two going. Sometimes, for someone with a generalized onset of epilepsy, I didn't put it in here, sorry, but clobazam or clonazepam, they're good. Particularly with the generalized onset epilepsy, sorry, they shouldn't be in that list. But some people, by the time they're getting to the epilepsy clinic, you know, people can be on 3 or 4 drugs or more.
There's also a question here, Alan.
Sorry, the people, see, we should be able to get them under control with one.
Okay, sorry for interrupting. That was just a question about gabapentin or pregabalin. Do you ever use those?
I use them for pain, but gabapentin, you know, is sold as an epilepsy medication, but we never use it.
Okay. And if someone has a history of depression or anxiety before you start their medication, would you avoid that anticonvulsant?
So I'm glad you raised that. So I would probably avoid levetiracetam. If they've got depression or anxiety, I probably wouldn't use this first. I'd use this one. I wouldn't use topiramate if they've got some depression in the background as well. Sort of not first line.
Okay. I wonder if we should move on. We've got a few more questions there, but I think you're going to answer some of them as we go along, and we can come back to them if you don't cover it.
Yep. Okay, so the take-home messages: remember to tell women of childbearing potential about the risks to the fetus of both epilepsy, medications, and their seizures. Okay, so the way I do it is I will say, well, look, the risk of a problem to your baby, if you weren't on it, didn't have epilepsy, and you weren't on any medications, is about 2 to 3%. And so that means, you know, 97 to 98% of babies, out of 100 babies, are going to be normal, but, you know, 2 or 3 may have problems. And the sort of problems are cleft palate and spina bifida. women with epilepsy who are taking medications, that risk doubles. So it doubles to about 5 or 6%. Some of the medications, it can be up as high as 8%, maybe 10%, probably not 10%, but 90 to 95 out of 100 babies are normal. But I just need you to know that the medications we use can cause risks to your baby. But having uncontrolled seizures while you're pregnant can also cause problems to your baby. So, you know, we need to make sure you're on the right medication at the lowest dose that controls the seizures. Valproate has probably twice the risk of fetal abnormalities than the other medications, so we try not to use it in women of childbearing potential. We start women on folic acid if you're of childbearing potential. The reason why is that people who are folic acid deficient have a higher risk of neural tube defects, spina bifida, cleft palate. They happen in children who are born to women with epilepsy on medications. We don't know if it works, but we give them folic acid anyway. So the next thing, she comes to see you 4 years later, she wants to become pregnant. And so when I see patients and I start medications, I talk about the safety, I talk about the driving, I talk about SUDEP, I talk about the risk to a baby if she becomes pregnant. You want to make sure she's on an effective contraceptive agent. And I say, look, when it comes time for when you're starting to think about planning a family, I want you to come back and see me or get referred to a maternal medicine specialist to make sure, one, you still need to be on medication, two, that it's the safest medication, and in the last, you know, nothing else has come up since I saw you last, and three, it's at the lowest dose. Okay, and that's also important because during your pregnancy, the requirement for the epilepsy medications may change. So, for example, lamotrigine, you've got to put the dose up during pregnancy, and then as soon as delivery happens, you've got to put the dose back down to where it was. And so we need to know that in advance before this happens. So come back and see me with your partner when you think it's time you want to have a baby. So I tell them that up front. You tell them they can still get pregnant. Make sure that that she's on appropriate contraceptive measures if she doesn't want to become pregnant. I always get uncomfortable because lots of women come in and they come and see you when they're, you know, they're 14 weeks pregnant, and that's always really tricky. The risk, the teratogenic risk, occurs in the first trimester. Okay, so that's when the neural tube's being formed. It's not just neural tube defects; it's learning difficulties as well. But it's in the first trimester, so you want to see the woman before she becomes pregnant, if at all possible. It's also important that the midwife or the obstetrician knows. So delivery, stressful, sleep deprived, you know, easy to forget taking a tablet. I can assure you the obstetrician or the midwife will not thank you if a woman has a seizure, you know, halfway during a delivery. It's not a good thing. So any questions about that?
I think you've answered most of them, actually. Someone missed the dose of folic acid was 5 milligrams right from the start of starting.
5 milligrams. The Australians put it in the bread. I understand there's a plan for us to put it in bread too, like sort of like iodine and salt.
Yeah. But other than that, I think the fact that she still needs treatment, which quite a few people have asked.
Yeah, she's still, well, you know, sort of, it depends. Sort of after 4 years, she'll be wanting to stop, and it depends on the sort of epilepsy. If she had a normal EEG at the beginning, and she hasn't had any seizures for 4 years, I might consider tailing her off. But you've got to tell the patient that as you do that, she can't drive, and those safety things kick back in again. And then she can't drive until she's been off all medications and seizure-free for 6 months. And so they're not usually keen to do that. If she had generalized changes on the EEG or a focal onset epilepsy with either you know, a hippocampal scarring or sclerosis or focal changes on the EEG, she's going to need to stay on medications.
Yeah. And while she's on the medication, she stays on that 5 milligram dose of the folic acid. You know, not just the first trimester of pregnancy, like with other women.
Yeah.
Someone's asked, what is the interaction between anti-epileptics and oral contraceptives? Is there an interaction?
With the old ones, yes. So carbamazepine and phenytoin, but the newer ones, not so much.
Okay. And would you recommend obstetric secondary care for pregnant women with a history of epilepsy versus?
What I'll see them in my clinic, and I'll refer a young woman to the maternal medicine specialist. So I do that routinely in the hospital or privately. That's what I do. Yeah, I mean, I don't know. So I suspect my woman neurologist colleagues may be able to do this better than I can, but that's what I do. They're very good. The maternal medicine is very good.
Yes, they are. They're very good. There is a couple of questions that have come through during your talk so far, just around the focal epilepsy medication management versus the generalized epilepsy.
No, I wouldn't worry about it.
Okay.
If you use the more modern medications, they work for everything.
Okay. Yeah, that's generally what it is.
In the olden days, when I was a registrar, you know, we'd use valproate for generalized epilepsy, and we'd use Tegretol for focal onset epilepsy. Mm-hmm. But these days, with the levetiracetam and the lamotrigine and the topiramate, it doesn't matter so much. So I don't think you don't need to get that picky about it. They all work.
Okay. All right. I think we should keep moving just for the interest of time, because we've got a bit more to cover. So let's go on.
So take-home messages. Ensure she still needs treatment. Almost always yes. That she's on the right medication, not valproate. If she's on multiple medications, try and get her onto one. That she's on the lowest dose that controls the seizures. I refer to maternal medicine, and the midwife obstetrician needs to know. The other thing to warn the woman is that, you know, after you've had your baby, you're going to be sleep deprived. You're going to want to breastfeed your baby, and there's a temptation to stop your epilepsy medications. And, you know, that puts you at risk of having a seizure. Sleep deprivation precipitates seizures. So I warn women that, you know, I want you to continue your medications after delivery. And you can often, depending on the medication, you can often keep on breastfeeding. But again, I'd defer to the maternal medicine specialists. Right. Okay. How are we doing for time? Well, let's we might get through 2 cases. So there are 2 long cases and 2 short cases. The first one was a long case. This is a short case. So 55-year-old man, sudden onset of right arm weakness, resolves after 5 minutes, comes in to see you in your practice. His wife says he had an episode yesterday where he couldn't find the right words, lasted a minute or 2. He's got fairly well controlled hypertension. He's a little bit fat, obese, and he's a lifelong smoker. And what's the diagnosis? And what do you do next? So what do you think's going on here?
So we've had a lot of people come back with a TIA. In fact, no one has said, oh, maybe a CVA, TIA. And people have suggested refer to clinic, a CT head. Someone suggested a hemiplegic migraine as a possibility.
You'd make a good neurologist.
Yeah. Aspirin, left MCA ischemia, a TIA, ECG for AF, carotid ultrasound, and blood.
Yeah. So this is 2 TIAs. One yesterday, left MCA, a non-fluent dysphasia, so Broca's area of the brain, and what was today? Right arm weakness, still left MCA. So 2 left MCA territory TIAs, and he's had 2 in 24 hours. We would call this crescendo TIAs. Don't worry about the fancy terms, just 2 TIAs. This man is at high risk of having a stroke, and the stroke is going to happen in the next few hours, the next 24 hours, maybe the next 48 hours. It's going to happen soon, okay? And the reason why is there is an unstable something going on in this man's body. So he's either got a clot in the heart that's breaking off little bits, he's got stenosis in the internal carotid artery origin at the angle of the jaw, with a plaque that's ruptured and you're getting blood clotting on it and bits of gunk being released from it and going up to the left MCA territory time after time. Or he hasn't got small vessel disease because he had dysphasia, so it's not one of the small penetrating vessels into the subcortical white matter that's been affected by atherosclerosis. So this man's probably got left ICA active plaque, and that plaque is still active, and he could have a stroke. So I absolutely agree. You need to get an ECG if you can get it. I mean, to be honest, he needs to be seen in the emergency department, and so I would send him into the emergency department. A quarter of strokes are preceded by TIAs, and you can stop 80% of those strokes happening in a person who's had a TIA. So I would do an ECG. I would give him an aspirin. The people get worried about aspirin, giving it acutely, in case it's a hemorrhage. So about 10 to 15% of strokes are due to intracerebral hemorrhage. But intracerebral hemorrhage isn't preceded by TIAs. Okay? So you can feel quite comfortable giving a patient 300 milligrams of aspirin while you're waiting for the ambulance to get them into hospital. You're not going to do them any harm. So that's what I would do there. And the investigations, ECG while you're waiting. Aspirin in the short term. So you send them into the hospital and they do a CT scan. We would do a CT scan on this man in the emergency department. We used to do carotid ultrasounds. I don't know if you've noticed this, but we're doing CT angiograms. So we do the brain CT, we give them some contrast, and we look at the neck vessels and the intracranial arteries to see if there's any stenosis. And we do it as a one-stop shop in the emergency department, same sitting as the brain CT. So it's all done. And that way we can start the appropriate medication straight away. And so what will those medications be? How do we treat stroke people or TIAs? What medications?
Statin, manage their blood pressure aggressively with antihypertensives. Clopidogrel, ACE inhibitors, clopidogrel, aspirin, dual antiplatelets, stop smoking. That was a good one.
That's a good one.
DAPT, lifelong clopidogrel. Pretty well the same thing. Clopidogrel, statin, antihypertensives,
yeah.
and stop smoking.
If we had a stamp on his note, in his notes or on his prescription pad. So patients with stroke, they require antithrombotic therapy. So either antiplatelet therapy, which is aspirin and clopidogrel. We hardly ever use dipyridamole anymore, so aspirin or clopidogrel, or if they're in atrial fibrillation, an anticoagulant. So, and dabigatran is a really good anticoagulant. So we almost never start warfarin anymore. So that's the antithrombotic therapy. They need one of those. In terms of the antiplatelet therapy, the clopidogrel is slightly better than aspirin. You've got to treat 180 people to prevent one who you treated with aspirin. The number needed to treat with clopidogrel over aspirin alone is 180. So the benefit over aspirin is tiny, but it's quite easy to take. And it's not particularly expensive these days. So clopidogrel is probably what we use, but aspirin's also good. It doesn't matter the dose of aspirin. We load people with clopidogrel and aspirin when we use it. But 75 milligrams of aspirin, 100 milligrams of aspirin's fine. We use dual antiplatelet therapy for the first 3 weeks. So a patient like this, or with a non-disabling stroke, so a minor stroke, we use dual antiplatelet therapy. And then after 3 weeks, we drop one, either the aspirin or the clopidogrel. Okay, because that gives you a slight added advantage while that plaque's still unstable. If you continue at dual antiplatelet therapy beyond 3 weeks, the patient's at increased risk of bleeding into the brain and elsewhere. And so there's benefit for the first 3 weeks in dual antiplatelet therapy, and then there's harm after the first 3 weeks. So it's really important that you stop one of those antiplatelet therapy agents. Everyone goes on a statin pretty much. We aim for a LDL of less than 2, less than around 1.8 or less, to be honest, but less than 2 is quite good. And we aggressively manage blood pressure. So, normal blood pressure is good, lower normal blood pressure is even better. As long as the patient's not fainting, we are quite aggressive. I remember when I was a registrar, we would tolerate blood pressures of 150 over 95. We don't do that anymore. Make sure the patient hasn't got, I think this patient's probably got left internal carotid artery stenosis. So if there is, in a patient like this, we'll take straight, the vascular surgeons will take within a day or two and do a carotid endarterectomy. So that's how we manage TIAs. Any questions about any of that, or any comments? Have I missed anything?
Alan, we've got a question. In the first 3 weeks, do you use antiplatelets and oral anticoagulants if there is AF as well?
Oh, sorry, if it's AF, so dual antiplatelet therapy is if there's no AF. If there's AF, dabigatran or an oral anticoagulant. So AF, oral anticoagulant, no AF, dual antiplatelet therapy for 3 weeks.
And there's a couple of questions about clopidogrel, and the effect has been shown to only be in a certain group of people, and that there are gene studies happening, and that there is someone's only 30% respond to it.
There are gene studies, and the people who are pushing this actually own the gene, actually own the test. So you've got to be very careful about that. But particularly in Asian people, I would probably avoid clopidogrel in someone of Asian descent because it's slightly more complicated. Remember, aspirin doesn't work in everybody either. So when we use aspirin, for every 100 people we treat after a TIA or a stroke, we prevent 1 from another stroke or death. Okay? Mm-hmm. So, the number needed to treat is 100. So aspirin itself is not that great, and clopidogrel is not that great. So we don't do, I know they do gene tests at North Shore. We don't do them at Auckland, but we would avoid using clopidogrel in someone of Asian descent.
Okay. Someone's asked if you can comment on the omeprazole reducing effect of clopidogrel. Omeprazole reducing.
Yeah, I know what you're talking about. If someone's on omeprazole and you're worried, use aspirin. I've got no problems with using aspirin. As I said, you've got to treat 180 people more than you can over and above what you treat with aspirin to save 1. So the benefit of clopidogrel over aspirin is tiny. So if you're worried, they're on omeprazole, give them aspirin.
Okay.
I don't think. I think it's. I'm not a very good neurologist because I don't think it's. I think it's important not to get too picky about things.
Perfect. Would you recommend all TIAs be? Oh, you go, Alan.
No. Sort of. I use Solazapral or Candesartan. I use aspirin or clopidogrel. I use I use atorvastatin. The statins are all pretty much the same. I mean, the drug companies will say one's better than another, but you just get, as long as you're using one, then that's a good thing.
Yeah. The question I was asking was, would you recommend all TIAs to be assessed urgently, or just because he had 2 similar episodes in a row,
Yeah, I would definitely get all TIA patients assessed urgently, and I'll tell you why in the next slide. This patient should go straight to hospital. You know, either put him in a taxi because he can't drive. Remember, people who've had a TIA can't drive for a month. People with a stroke can't drive for 3 months, and only then when they're back to normal. But anyway, this man needs to be seen. He's at a very high risk of having a stroke. The ARCOS study, which this talk was supposed to be about, but because of COVID-19, we've put the ARCOS study on hold. We showed 10 years ago that 80% of TIA patients in the Auckland region were being, the ones that you identified and we identified, were being seen in hospital, either in a clinic or in the emergency department. And you know, we want to see these patients quickly. Now, the proviso there is that we want to see TIA patients quickly. So TIAs are quite characteristic. So TIAs don't cause a loss of consciousness. They don't cause dizzy doos or dizzy spells. They don't cause isolated vertigo with nothing else. You know, the brain stem's this thick, the dizzy center's there, the vertigo center's there. It's very unlikely you're going to get a little blood vessel that's picked off just the vertigo center and nothing else. So a brainstem stroke, you get other things as well. You get dysarthria and double vision and ataxia. So isolated vertigo is almost never due to a TIA. So TIAs do cause hemianopias. They cause facial, arm and leg weakness, one or all of those parts. They do cause numbness on one half of the body, and they can cause slurred speech along with those other things. They're quite definite. When you see a lot of them, they're quite definite. And we definitely need to see those ones. We don't need to see the isolated vertigo and the lightheadedness when they stand up patients.
Okay, let's keep moving in the interest of time. And I think you cover off some of the next few questions.
So I'm sorry for talking so much. The take-home messages are, you need to take TIAs, and the ones I'm talking about, you know, not the dizzy spells, but you think this is definitely a TIA, you need to take them seriously, because the risk of an adverse event is more than with unstable angina. So these patients are more likely to die, have a stroke, which can sometimes be worse than dying, or even have an MI. They have a very high risk of having problems. And, you know, while you're waiting to send them in, if it's a single one and you're waiting for the TIA clinic, get an ECG checking for AF. You know, send them off for some routine bloods, including fasting lipids and glucose, so it's there when they're seen in the clinic. And we'll obtain a brain scan and vessel imaging on them. The medications that we use to treat TIAs, as well as doing endarterectomies in people who need an endarterectomy, we can reduce the risk of a TIA patient having a stroke by up to 80%. So it's worth taking these seriously. You don't want your patients having strokes. I'm a stroke specialist, they're devastating. And so endarterectomy if there's choroidal stenosis, antiplatelets, anticoagulants if AFib, pretty much everyone goes on an antihypertensive and a lipid lowering agent. Any final questions about stroke?
Yeah, just one more before we move on, just again in the interest of time, there's been a few questions about using the ABCD score in the community, yeah. and we can manage patients in the community if they score low.
Yeah, we're less worried about it if it's low, because really an ABCD score that's low, there's a less chance that it's a real TIA. But the ABCD score was really designed for emergency departments, where you get you get a house officer working in an ED, someone comes into an emergency department with, problems finding the right word that lasted for 2 minutes yesterday or 3 hours ago. What was happening was the patients weren't being taken seriously, and they were being sent home and coming back in with a stroke. So the ABCD score was designed with that in mind, so that we would take TIAs seriously. If you think it's a TIA, they really need to be seen in a hospital clinic. It'd be like you managing unstable angina at home. Now, if you can get a CT scan and an ultrasound, or a CT scan and imaging and ECG and you can start these medications, that's also okay. But you need to do it straight away.
And there's a last couple of questions here around what if someone presents late? So 3 or 4 days after their TIA, they come and see you and explain what has happened. They haven't had any episodes since.
That's a good question, because what happens is that the risk of stroke decreases after about 72 hours, 48 to 72 hours. So the risk of stroke is up front in the next 24, 48 hours, and then the risk goes down. And by the time you're getting to a week, the risk is much less. But you want to try and stop the patient having a stroke in that week. So, so we will often, if you called me and I'm on taking the acute neurology phone for ADHP, and you said, oh, this patient came in, they were in Fiji, this happened a week ago, and this, you know, I become less, you know, I'm not going to send them into the emergency department. Whereas if they're having it now or 10 minutes ago, then I would definitely get them into the emergency department. Does that make sense?
Yeah.
Because the unstable plaques started to sort itself out.
Okay, let's move on to the next one.
Okay, you're holding up? Right. Okay, so this is another doozy. This is a good one. So 50-year-old woman presents with daily headaches. They've been there for 3 months. When the headache's at its peak, because it fluctuates, all headaches fluctuate, her vision seems a bit blurred. There's no other neurological symptoms, and she's taking daily Panadol and ibuprofen. Okay? What's the differential diagnosis and why? What investigations, if any, are required and why? So what's going on? Daily headaches, 3 months, blurry vision, daily medications. What's going on? What do you think? What's your differential diagnosis?
Okay, so I'll read some out. We've got rebound headaches, medication overuse, analgesia overuse, tension headaches, migraines, tumour, medication overuse recurrently, neck tension, menopausal induced headache, more arteritis temporalis, ongoing medication overuse is the most common one coming through.
Yeah, I'm really glad you haven't said anything that's rare, which is great. You know, like, you know, the sort of the funny headache syndromes that I hardly ever see as a neurologist. This is one of 3 things. Well, it's one of 2 things with a third thing helping. It's either migraine, tension type headaches. The daily paracetamol and ibuprofen are actually keeping it going. So that's called medication overuse or rebound headaches or medication overuse headaches or analgesic overuse headaches. It's all the same thing. So I call it medication overuse. And I explain to a patient, you know, this is probably tension type headache. I explain tension type headache. You know, it's sort of the muscles in your scalp become tense. You spend all day doing this in front of a computer. You know, you're going to get a headache, you're going to get a neck ache. The tension type headache is the same sort of thing. But what happens is if you're taking daily painkillers, it actually keeps the headache cycle going. And when you talk to the patients, what they do is they start anticipating headaches and they'll take analgesics in advance. And then they just get into this vicious cycle. So tension headache, migraine. And so, you know, the vision gets a bit blurred during the peak of the headache, possible. And the other thing is, in this woman, tumor. And how would you what would make you worried about a tumor in this woman? For those fast types out there.
Age has come through, new onset, breast, red flags, symptoms waking her at night, blurred vision, morning headaches.
Again, I wouldn't get too many of those lists. So the headache at night, you can get that with migraine. The waking with headaches characteristically happens with tension type headaches. So, you know, I remember getting taught all these things. You know, a headache that wakes someone from a night that you're worried about a brain tumor. I wouldn't worry about that. This is a 50-year-old woman. What you want to know is, has she had this before? If she's been having this all her life, it's not a brain tumor. Okay? And if she had a scan 10 years ago, maybe 5 years ago, I wouldn't do another one unless there was a significant change in the character of the headache. But if she's never had headaches before and they're daily and they've started 3 months ago, then that's a brain tumor until proven otherwise. Okay, does that make so? Tension type headaches, migraines, medication overuse headache, which really is not a headache in itself. It just keeps the other two going. And you know, if this is a new onset headache in a middle-aged person, then you need to exclude a tumor. And so, if this woman had never had headaches before, I'm going to get a CT scan within the next couple of days. Now, the take-home messages, because we're running out of time, is headaches really common. It is the major cause of neurological disability. More work days are lost from headache than any other neurology problem, and it's way up the top of any problem. You know, it's miserable. Almost always tension type, migraine, and you need to check for medication overuse. Taking an analgesics more than 15 days a month will keep a headache cycle going. Okay? Headaches are almost never due to cluster headache or other rare headache disorders. Okay? I have in my practicing career in the last, I don't know how many years, 20 years as a neurologist, I've seen about 4 or 5 people with cluster headache. So you will see them occasionally, maybe once in your practicing career, but you know, I've seen 5 as a neurologist. It's pretty rare. And it's quite different from migraine. People get confused because migraine often focuses on the back of the eye, retroorbital pain, nasty. People can get a bit of tearing in their eye and redness of their eye. Cluster headache's different. Cluster headache's like a knife in your eye. It happens in the middle of the night. It wakes you up. There's a periodicity to it. Migraine people want to lie down and sleep and close the curtains. Cluster headache people wander around moaning with their hand on their head, moving. So it's quite a different sort of thing. So the headaches are almost always tension type, migraine with or without aura. Often the headaches that are ascribed to neck problems are tension headaches. Similarly with TMJ problems, you know, the patient's often got a migraine or having migraines, and someone's done an X-ray and seen some arthrosis in the TMJ joint, but it's usually tension type headache or migraine. But beware the new onset headache in the middle-aged person, and they need it. So once someone hits 30, I do scans on them. Someone with headaches in their teens and 20s, if there's no red flags, I don't do CT scans. If you did a CT scan on everyone who ever had a headache in their teens or 20s, you'd cause more brain tumors from the radiation of the CT scan than you'd actually pick up. So tumors can certainly happen in teens and 20s, but there are other red flags that go with it as well. It's almost always migraine in the teens and 20s. And someone mentioned giant cell arteritis. I get worried about that after 55. But the patients often got other things as well. So they get jaw claudication, they're chewing and they sort of lose steam. It's sore to brush their hair or wash their hair because they get scalp tenderness. And when you feel for the temporal arteries, you know, quite big ones, you can't feel the pulse because there's arteritis. And those patients need a CRP. So anyone who's over 55, just do a CRP. Don't even think about it, just do it. Okay? Any questions about what we've talked about? We're going to talk about treatment in a minute, but any questions up until this point?
Yeah, I think we should move on to the treatment because there are a few questions around the treatment. So I think you're going to answer those as you come along.
Okay, well, regarding therapy, how do you treat this woman's headache in the acute phase? Let's just say she's had a CT scan and it's normal, and I did a CRP and it's normal as well. So there's no brain tumors. How do you treat her? What do you tell this lady?
So we've got to universally stop her medications or withdraw her slowly off her analgesia.
Yeah, in fact, I go cold. I get them to go cold turkey because it's miserable, and they never do it. And so my spiel when I talk to someone like this, because I've seen about 3 people like this today, is look, the CT scan is normal, your examination is normal, there's nothing nasty going on here. Doesn't mean that what you're feeling isn't miserable, because it is. But I think you've got what we call tension type headaches, and I don't know how it started, but you've got yourself into this vicious cycle where you're taking painkillers every day, and that's actually paradoxically keeping the headaches going. So what I would like you to try and do is on Friday evening, I want you to cancel all your social engagements, tell your family you're going to be miserable and to leave you alone, and I want you to stop all your painkillers. Don't do it today because you've got work tomorrow. Do it on Friday. And the first few days are going to be absolutely miserable. You're going to hate me. But if you manage to do that, there is a 50% chance that the headaches will go away. And for those people whose headaches don't go away, they're still happening, they're no worse, and you're not poisoning yourself with Panadol and ibuprofen. So give it a go. Okay, so that's what I tell people. And as long as I know what's coming, that it's going to be really miserable, that seems to help. I usually give them an out. If you try that and it doesn't work and you absolutely can't manage, then I want you to grade your headaches into mild, moderate, or severe. You can only have painkillers for the severe headaches, and the severe headaches can happen on no more than 15 days in a month. So I want you to be painkiller free 15 days in a month. That doesn't mean you can have Panadol on those 15 days and ibuprofen on those 15 days. So I want you to have no medication in your system 15 days. So that's how I tell people. That's what I tell people.
Alan, a quick question. A number of people have just asked, how long does the misery last? How long do you expect her from that Friday night till she feels better, if it's going to work?
It's going to take, it usually takes about 4 or 5 days. It's actually quite miserable. So, you tell them that. You just say, look, this is going to happen. If it's coming up to Christmas, I say, wait until after Christmas. But when you think you can have days off work, then do it then. As long as you tell people, they surprisingly often do it. And they don't get worse. There's a 50% chance they won't get better, but they don't get worse after that first little bump. Okay, so what do you do to prevent further headaches? Normal CT scan, normal CRP. She's come off the painkillers, or she can't really come off. She's got down to 15 days in a month. She's still getting headaches. How do you treat it to prevent further headaches? Give me some medications that you might use.
So we've got tricyclics, nortriptyline, Topamax, coffee.
Yeah, absolutely. Yeah. I get migraines. I Panadol.
Yeah. Lifestyle measures, a lot of lifestyle measures, physiotherapy. There's been gabapentin and some beta blockers suggested.
Okay, well, those are the answers, basically, all of those answers. And so there's a gradation. What I've got my own hierarchy of medications that I use. So the top 2, I'd use nortriptyline or amitriptyline. Probably amitriptyline's a little bit more sedating than nortriptyline, but either or topiramate. So one of those 2. If someone's got a little bit of depression, I'll use amitriptyline and avoid topiramate. Okay. So those are the 2 medications, and you lay on the side effects thick. Okay. So these are preventative agents. They're not painkillers. They take a few weeks to work. If you start tonight and you get a headache tomorrow, don't throw them away, because they were never going to be helpful after one day. You just have to persevere. And the side effects, amitriptyline, dry mouth, blurry vision, make you feel spacey. For the first few days, you may feel a bit miserable, but that's why we give it to you at night. We start at a really small dose and increase it slowly. You might have heard from your friends that it's an antidepressant, but the doses we're using aren't antidepressants, and I'm not using it because I think you're depressed. It just helps headaches. With topiramate, it takes a little longer to build the dose up, and if someone's got a mood disorder, I probably wouldn't use it as first line, because it can make people feel a bit depressed. People lose weight on it. That can be a good thing. You know, start at 25 milligrams at night for 2 weeks and then 50 milligrams at night. So those are the two top ones. Second here would be beta blocker for a migraine anyway, less good for a tension type headache. Beta blockers, propranolol or nadolol. They're actually quite effective for migraines, but people get a bit lethargic on them. They put on weight, and their mood can go down a little bit as well. So I'd have that as a second line. So those are the medications that I use. I tend not to. You can often help people with one of those. Okay, there are other medications. There's Sandamigrin for migraines. I can't remember the last time I used it. Gabapentin, I'm not even sure it particularly works that well with migraines. It's good for pain, but not for migraines. The metoprolol, not really good for migraines. So those are the things that I'd use. And if someone's having problems and you can get physiotherapy, that's good as well. The really important thing for chronic headaches is just setting the patient's expectations. I don't have a magic bullet. We may have to try more than one medication, but let's see how we go. And once people have had a CT scan and they've seen someone about it, and you reassure them, things often improve. I mean, easy for me to say as a neurologist, but any questions about any of that?
Alan, have you had many women complaining of hair loss on topiramate?
It can cause hair loss. To be honest, no, I haven't. Probably because they don't come back and see me because they've had hair loss with the medication I use. But no, I haven't seen it, but it can certainly happen. If you tell a woman that one of the side effects is hair loss, they're never going to take it.
No.
If you tell people that one of the side effects is weight loss, they definitely take it.
There is a question here about the consideration of estrogen in post-menopausal women. Ah,
well, fun. Oh, you mean as a treatment?
Yes.
Or
as a treatment?
I mean, I wouldn't use it as a primary treatment. I reckon just with these simple things, you can get most of the people under control. The lifestyle measures definitely lifestyle measures. You know, eat less, drink less. You know, world peace. The lifestyle measures are often harder to implement than say. Certainly, exercise is good. Get yourself out and do some exercise. That's a good one.
And magnesium in particular, lots of people have asked about magnesium as a supplement.
I mean, you can use it as a supplement, but I mean, I don't think there's any particular evidence that magnesium is any good. I don't use it, so I don't think there's any particular evidence about that. But you know, it's not going to do them any harm.
Yeah.
So I've got no problems with it.
Okay, let's keep moving on. We're already a little bit over time, but if everyone's happy, we'll keep going. So it's great talking.
Okay, these are take-home messages. Painkillers on no more than 15 days in a month. If you can, go cold turkey. It's short, sharp, and painful, but as long as you set the expectations and they know what's happening and they know what to expect, they'll often go through with it. Triptans, no more than 10 days per month. This is really important. This is another take-home message. Immigrant, sumatriptan, rizatriptan, it's particularly bad at causing medication overuse or rebound headaches, really bad. And so, you know, I tell the patient no more than 10 days in a month for a triptan. Don't use tramadol or opioids. Please don't use them. I know it's hard not to sometimes, but we don't use them in hospital ever, ever. And we'll try and get people off tramadol and opioids. That's for the acute therapy. Preventative therapy, this is basically all I use. Amitriptyline, nortrip, topiramate, or propranolol second line, and only for migraine. And you can, you know, good explanation, normal CT scan, you can usually get things under control. I think I think this is the end of it. We'll leave the last case, but this is the end of it. Tell patients that these aren't painkillers. Set expectations. They're not analgesics. they've got side effects, they take several weeks to work. I lay it on thick. You know, this is, you know, I haven't got a magic bullet. It's going to take a little while to get there, but you know, I say to people, there's a 60% chance that amitrip will work, and if that doesn't work, there's a 60% chance that topiramate will work. So there's a good chance they'll work, but we just have to be patient, and it ain't going to happen overnight. So I always tell people you need to be on it for at least 4 to 6 weeks before you throw them away as being useless. If they work, you're on them for 3 to 6 months if they help, and then you can start tailing them down. Headaches don't come back, throw them away. Headaches come back, go back on them for another 3 months. Any questions about the treatment of these?
There's a question here about the combined oral contraceptive pill being contraindicated.
That wasn't my last. That wasn't my last. This is my last slide. So migraine in young women.
Yes.
There's a small increased risk in stroke if you've got migraine with aura. Not common migraine, but migraine with aura. So the visual symptoms or the sensory symptoms. But if you're a 20-year-old with migraine with aura, your risk of stroke is minuscule. So double a minuscule risk is a tiny risk of stroke. Okay? If you're 35 and you're overweight and you've got diabetes and your blood pressure's up and you're a smoker, your stroke risk is not small. And double, you know, sort of, you need to avoid estrogen-containing pills. And sorry, I've got confused there. Different talk. You need to avoid estrogen-containing oral contraceptives because it can increase your stroke risk. So what I was trying to say there is, if you're a young woman, I'd still avoid an estrogen-containing pill and use a progestogen or something else. But if you're really between a rock and a hard place, your risk of stroke is really small. But once you're getting up to 35 with multiple other vascular risk factors, your risk of stroke is increased. If you've got migraine, you should not use an estrogen-containing pill. Estrogen-containing pills can also worsen. So you often see that people's migraines flare up after they start the pill, or change to a different pill. And if that happens, you just change them to a progestogen-only pill. So that's the last slide that I've got. We've got through 3 of the cases. Any final questions about headaches or anything else you want to ask me in the last minute?
Alan, there's a couple here. One is a patient had a case, a doctor had a case of a patient with acute glaucoma on Topomax. Have you seen that before? No, I haven't. But rare things can happen, but they happen rarely. No, but I haven't seen that. Yeah. Does topiramate work in chronic daily headache prevention, which may not be migraine headache?
I'm not sure. It's worth a crack, but my experience is that the tricyclics are the best for chronic daily headache, tension type headache. that and stopping the analgesics. Topiramate really good for migraine, and the beta blockers are really good for migraine. They're not so good for the chronic daily headaches.
Okay. There's been a few comments throughout about the use of neck manipulations in patients and whether that you've seen an increase in TIAs or issues with headaches after these.
I've certainly seen someone have a stroke with chiropractic manipulation of their neck. They had a vertebral artery dissection. So there's an increased risk of vertebral artery dissections with chiropractic manipulation of your neck. Osteopaths are much more gentle. They don't, and physios, they don't sort of graunch your neck, but the chiropractors graunch your neck. I try to warn people off. Go and see a chiropractor, but get them to do something with your back and not your neck. Okay. If that makes sense. If they want to see a chiropractor, just tell them the neurologist said, don't manipulate my neck.
Great, that's some good advice to be able to pass on. There's been a couple of questions about headache in kids and whether you could just run quickly over the differential that you think about obviously the more severe problem.
I don't see kids. Well, that's the problem. I don't see people over 16.
Fair enough.
But
That's
I
an
guess
unfair question.
I guess it's going to be migraine as top of the list, and kids get tension type headaches as well. So those are the two major causes of headaches, I think, in kids as well. I did a pediatric neurology clinic when I was a registrar once a week, and they were the main, it's mainly migraine.
Yeah. No, look, that's fantastic, Alan. I think that's most of our questions there. There's been lots of comments about the lifestyle changes, and I think you've covered them really well, and you've really commented strongly on explaining about the analgesics and hammering them about side effects, which I think is really good to hear from our point of view as GPs, trying to stop people from overusing analgesics, and especially the opioids. And
well, when they come and see me with chronic daily headache, they know, they've been told, they know that my GP said I shouldn't take so many painkillers, but what can I do? It's really sore, So I know you're telling them.
Yeah. Look, that's fantastic. So thank you, Alan. That's been a wonderful talk. There's lots of great feedback from everyone about how useful that's been. So we really appreciate it, and I think a lot of really great tips that we can start using straight away. So thanks very much.
Yeah, I mean, it's important not to make neurology too complicated, because what I've covered tonight, the next case was a short tremor case. What I've covered tonight is most of neurology. So, and that's how I approach it. I approach it very simply, without getting into too much detail.
Well, it was a fantastic presentation. Thank you.